Good morning, professors. Good morning, my teachers. My name is Dr. A.K. Chineme, and I'll be presenting the National Postgraduate College November 2023, question 10. Okay. This is a case scenario of a banker non-hypertensive with type 2 diabetes, height about 200 centimeters, weight about 180 kg, presented with sudden onset pain in the right big toe and ankle. Symptoms usually worse after going to party with his friends. He was on medications including hydrochlorothiazide and aspirin. So the question says, what is the most likely diagnosis? Mention 3 differential diagnoses. What is the most important investigation? What drugs will you stop? Mention 3 drugs for acute treatment. Mention 2 classes of drugs for treatment of chronic phase. And what are the other comorbidities, stroke risk factors associated with this condition? So of note in this question is the fact that the patient is diabetic, is also hypertensive. He presented with a sudden onset pain in his right big toe. He went partying with his friends, which he may have taken a lot of alcohol, and also he's on HCT and aspirin. So for this, the most likely diagnosis is acute gout based on what I have explained. 3 differentials include pseudogout, septic arthritis, rheumatoid arthritis. What is the most important investigation for this patient is joint aspiration and synovial fluid polarized microscopy to identify crystals, which is the gold standard for diagnosing gout. What drugs will you stop? The patient is on aspirin and HCT, which induces increased uric acid. So this drug should be stopped for the patient. Mention 3 drugs for acute treatment. Acute treatment, we can make use of non-steroidal anti-inflammatory drugs, colchicine and corticosteroids. Mention 2 classes of drugs for chronic phase treatment. We have the xanthine oxidase inhibitor, like allopurinol and febuxostat. We have the non-recombinant uric acid inhibitors, uricase, rasboricase. We also have uricosuric agents that can be used for chronic gout. So other comorbidities and risk factors associated with this condition include hyperuricemia, male gender, age, obesity, alcohol use, diabetes, renal failure, hypertriglyceridemia, hypercholesterolemia, high purine foods, metabolic syndrome, tumor lysis syndrome, drugs including furosemide, cyclosporine, salicylate, parazinamide, levodopa, ethambutol, fructose-rich foods, myeloproliferative disease, and dehydration. So having answered the question, we'll quickly look at gout. So gout is an inflammatory arthritis characterized by recurrent attacks of red, tender, hot, and swollen joints caused by deposition of needle-like crystals, specifically the monosodium urate crystals in the joints and soft tissue. The diagram which our patient presented with occurs in about 50% of patients and is one of the most common symptoms they present with. It's been found to be about 3.9% in adults, and if you have a family history of gout, it increases to about 20%. It's more seen in increasing age elderly. We have it about 5 times in 70 to 80 years. And then male preponderance over females. Male, we have about 5.9%, and female about 2%. It's usually of early onset in the males, 40 to 60 years, and usually late onset in females, 60 to 80 years, basically because of the effect of estrogen. Estrogen is uricosuric in nature, so most times it comes up when the woman is postmenopausal. And then we have it more in African Americans than in Caucasians, generally because of our high risks for hypertension, diabetes. Hence, we may have to be on those drugs and increases our risk factors for that. So generally in gout, the main problem is that there is monosodium urate crystals, which are actually breakdown products of purine. So when we take in purine foods, they break down to form uric acid. When we have very high levels of uric acid in the blood, they crystallize to form urate crystals, which now get into the joints and also get into the tissues. So the main issue is either there's an increase in the production or there is a reduction in the excretion of the amount of uric acid that is being produced. So once there's formation of urate crystals, this leads to increased inflammation and increased movement of neutrophils, inflammatory cells, and this results in the redness, the swellings we see in our patients that come down with gout. It's also important to note that high temperatures, increased acid levels also precipitate uric acid movement to urate crystals and hence symptoms. The risk factor include hyperuricemia. Hyperuricemia is a key risk factor for gout, but it's important to note that not all patients with gout have hyperuricemia. And also the presence of hyperuricemia without symptoms is not gout. Other factors include male gender, age, obesity, alcohol use like in these patients, diabetes like in our patients, obesity, hypertriglyceridemia, hypercholesterolemia, renal failure, which will lead to reduction in the excretion of uric acid and hence predispose our patient to this. So we have basically two types of gout. We can have the primary gout, we can have the secondary gout. We can also divide it into acute gout and chronic gout. So for the primary gout, it is basically divided into the causes of increased production, like in genetic causes like Leishmanian syndrome, glucose-6-phosphate deficiency, fructose 1-phosphate aldose deficiency, and then the superactivity of phosphoribosylse synthesis. It can also be from high cell turnover. So patients with myeloproliferative disease, lymphoproliferative disease, psoriasis, hemolytic anemia, tumor lysis syndrome, where the cells have to be broken down over and over again. That leads to high uric acid, excess exercise, and obesity. So also you can have it as a result of the reduction in the excretion of uric acid, like in patients with renal failure, radio contrast eye can also affect kidneys and reduce excretion. Secondary gout is usually as the result of other causes that may influence the production and the excretion. For example, if you take purine-rich foods, fructose-rich foods, it might lead to increased production of uric acid, renal failure, dehydration, alcohol, drugs, which we have listed earlier, can also result in increased uric acid. So the clinical features include redness, pain, swelling of the affected joints. It's important to note that the podagra which occurs is common, but gout usually affects the distal joint, small distal joint, usually asymmetrical, as if you when compared to other differentials like pseudo gout. So it's also important to note that the attacks are abrupt and it reaches a maximum intensity in about 8 to 12 hours. The patient may have fever, migratory polyarthritis, might be deposition of the urate crystals in tissues, forming what we refer to as tophi. There might also be eye involvement based on deposition of urate crystals. The differential diagnosis are pseudo gouts, which can be differentiated. They are usually symmetrical. They usually are caused by calcium pyrophosphate as against gout that is caused by monosodium urate crystals. They are usually more with larger joints and proximal joints as against gout that are usually with distal joints and smaller joints. And also for them, majorly they have other things like carpal tunnel syndrome as against gout. And then most times their treatment isn't really specific, although it's been shown that DMARDs can be used for pseudo gout, unlike gout, that their treatments are more specific. Septic arthritis is a differential diagnosis because it can come with redness, swelling. So for these patients, what is important is also synovial fluid for MCS and also blood culture. They can also check cell counts, glucose levels in the synovial fluid just to rule out septic arthritis. Other differential diagnoses are reactive arthritis, cellulitis, psoriatic arthritis, acute sarcoidosis, amyloidosis, rheumatoid arthritis, bursitis. What are the complications of gout? Severe degenerative arthritis can occur. It can be secondary infection, both of the tophi and also of the joint affected. You may have uric acid nephropathy, damage to the kidneys due to high uric acid levels. It can also have spinal cord impingement of the urate crystals. So fascious gout, where we have tophi located mostly at the earlobes, the fingers, also the toes, and even around the knees we can find, and the elbow joints we can find to fascious gout. The patients that have to fascial gout can also have fractures of this to fascious gout. So what are the investigations? It's important to point out that the gold standard for diagnosis of gout is joint fluid aspiration, synovial fluid analysis for polarized microscopy, where we see needle-shaped crystals that are yellow and they have negative birefringence. This is also a distinguishing factor from pseudogout, where we find rhomboid-shaped crystals that are blue in color and they have a positive birefringence. Cell count and differentials are important to exclude septic arthritis. Gram stain culture and sensitivity is also important to exclude infections and also septic arthritis. Now, the serum uric acid level is not a diagnostic test for gout, although it can bring forth the increased risk factor of hyperuricemia. And it's been found that 95% of patients with gout have hyperuricemia. We also have 15% of patients that have normal uric acid and still come down with gout. So hyperuricemia without the presence of symptoms is not gout. But if you have a normal uric acid level with the presence of symptoms, that is gout. So gout patients can have a hyperuricemia or they can have normal serum uric acid levels. So this serum uric acid levels is important, but it's not a diagnostic test for gout. 24-hour uric acid excretion is also an important test. In this patient, we usually use it to determine if we are going to give the patient uricosuric acid, uricosuric agents like probenecid or not. So if normally the excretion rate should be about 800 milligrams per DL per day. So if the patient is already excreting 800 milligrams per DL per day, is equivalent to the fact that you don't need to use probenecid because it increases the excretion. The patient is already excreting normally. So what you need to do is to stop the production of the uric acid by the use of xanthine oxidase inhibitors. So we can use this 24-hour uric acid excretion to know if we're going to place a patient on probenecid or not. Also, in high-risk patients where they have renal calculi, it's been said that when the excretion is more than 1,100 milligrams per DL, you have risks of renal stones and renal nephropathy. So in this patient, it also guides our treatment. Imaging is very important in the patient, although the features usually come up when the gout has been for at least 1 year and more. So pathognomonic features in plain X-ray include maintenance of joint space, absence of periarticular osteopenia, sclerotic borders, which we call the cookie cutter appearance, and then you also have asymmetrical distribution among the joints with predilection for small distal joints, and above all, the overhanging edges, which is also called the rat-beating appearance, that is pathognomonic of gout. Ultrasound of the joints can be done where we see the double contour sign. Usually you see a rim of monosodium urate crystals, which is actually hyperechoic, and then you see another rim of the bone structure itself. That's what gives the double contour sign. You can have wet chimps of sugar sign, which is interfacial gout and bony erosion. Other investigations include a full blood count, which will help us rule out septic arthritis by an elevated white blood cell count. Fasting lipid profiles to show risk factors of hypertriglyceridemia and hypercholesterolemia, liver function test because of the drugs we are going to commence, and EUCR to be able to exclude renal disease. Treatment of the patient is basically divided into 3: treatment of the acute gout, prophylaxis to prevent acute flares, and then control of the uric level when the patient is stable to prevent increased deposition in tissues and recurrent attacks. We have what we refer to as a treat to target, which is usually done within 6 months. Our aim is to reduce the serum uric acid level to less than 6 milligrams per DL in patients with just plain gout, and less than 5 milligrams per DL in patients with tophaceous gout or frequent attacks, or patients with nephropathy. Oh, okay. So we also have to reduce the tophi number in size, pain reduction, reduce attacks. So treatment of acute gout, the goal is to relieve pain and inflammation, where we use NSAIDs such as indomethacin. We don't use aspirin because aspirin actually increases uric acid. So it will lead to more of the flares. Then we can make use of corticosteroid, where we place the patient on 40 milligrams 1 to 3 days, and then we taper over the next 2 weeks. Colchicine can be done for our patients within 36 hours. ACTH is usually used to stimulate corticosteroid production from the adrenals. And interleukin-1 antagonist and Akinra has been shown to be used in treatment of acute gout. So the second point is prophylaxis to prevent acute flares, where we place our patient on low-dose NSAIDs for 6 months to prevent flares, low-dose colchicine also. Now, the third part of the treatment, which is the urate-lowering therapy when our patient is stable, we can make use of xanthine oxidase inhibitor, where we use allopurinol. It's important to state that allopurinol has its own side effects. It also has hypersensitivity. It's majorly excreted through the kidney, so when in use, we should reduce the dose if the patient already have a renal disorder. Then also, the maximum dose is 800 milligrams per day. We start at 100 milligrams and titrate upwards based on the level of uric acid we see. Then we can also make use of febuxostat, which is in the same class. It's better than allopurinol. They said it's more efficacious, and also because it's excreted more in the liver and the kidney, can also be used in our patients that have reduced renal function. However, the cardiovascular risk is increased. We also know that hyperuricemia on its own is a cardiovascular risk. So if the patient already has so much cardiovascular risk, febuxostat also increases the cardiovascular risk. We also have non-recombinant urate oxidase inhibitors like uricase, rasburicase, and finally uricosuric agents like we say probenecid, used in patients that have reduced excretion of uric acid. So if the excretion of uric acid is okay, we would go with the xanthine oxidase inhibitors to reduce the level of uric acid because the patient is already excreting normally. Then other agents that has been used is lesinurad and vitamin C. Non-pharmacological management will counsel our patients to reduce purine foods, stop medications that cause flares, avoid high fructose foods, high-level hydration for our patients, low cholesterol diet, and above all, weight reduction. So in conclusion, gout can be treated successfully. Prognosis is good in the absence of complication. Early diagnosis and treatment is key. Thank you for your attention. Good morning.
Thank you, Dr. Eke, for a wonderful and lucid presentation. The house is open for contributions, comments. Any contributions? Yeah, it was a wonderful presentation. Dr. Eke, aspirin.
Yes, sir.
Yeah, so in part of the drugs that that could cause retention of uric acid is aspirin. So, but it's dose dependent. So higher doses of aspirin are uricosuric, while lower doses are, can retain uric acid. So since this patient is diabetic and hypertensive, we assume that most likely it's having lower doses of aspirin. So it's nice to note that aspirin is dose dependent. So I said for patients, for example, for patients that have started allopurinol before an acute flare, do you stop allopurinol?
Okay, so thank you for your question and thank you for your contribution. Patients have already started allopurinol. We don't stop the allopurinol because usually if you can maintain that dose, or most times they say decrease the dose, because if you stop it, that imbalance in the uric acid will automatically worsen the flare and increase the flares. But if the patient has not started it, don't add it, because once allopurinol comes in, drops the uric acid levels, there's imbalance. So the acute gout would be more serious and will extend for a longer period. So that's what I think.
Okay. Thank you very much. From the messages, well, most people are applauding your presentation. Then Dr. Olaruwaju is saying, what's your take concerning xanthine oxidase inhibitors during acute flare? I think it's a similar question that you just answered. Then Dr. Chidima said, lovely presentation. Please, was losartan mentioned in the treatment? And then Dr. Itohan was asking, what are the purine containing foods? So those are the few comments that I can see. So what are the purine foods? Was losartan mentioned in the treatment? So you can go ahead and answer.
Thank you. Okay, thank you, sir. Thank you for your question. Losartan was not mentioned in the treatment of gout from the sources I checked. So that wasn't mentioned. I didn't see it anywhere where losartan is used as treatment for gout. So I don't know if someone has seen it anywhere, but I didn't
Yeah,
see anywhere that
yeah,
losartan is
losartan is
used.
not part of the treatment regimen, but for somebody that
Yes.
is hypertensive, you want to give ARBs.
Yes,
Okay,
you can switch
losartan
because
has been,
ACAI causes gout.
yeah, and then I think losartan has been shown to have some uricosuric, property. So even though it's not part of the treatment of gout, but if someone is hypertensive and you have the opportunity to give or switch to any antihypertensive, it would be nice to start with an ARB. Losartan has been extensively studied.
Dr.
Yes, yes, ma'am.
Dr. Asekeme, the rheumatologist, his hand is up. Let him just give us
Oh,
some
okay,
clarification.
okay, all right. Go ahead. Before.
Thank you so much, and good morning, seniors and colleagues. Okay, so to answer to a few comments, so to answer the question about losartan, actually, what Dr. Atta said is correct. It has some uricosuric effects, and actually, a large part of the well done, Dr. Chineme Eke. One of the things that I think maybe could have been in the presentation was that gout it's a part of this whole extended spectrum of the metabolic syndrome, what we call the syndrome X or Riven syndrome. So a part of the management of gout is actually looking out for components of the metabolic syndrome. And you can see so in the question, some of those components we actually highlighted. It's actually pointed that it's part and parcel of the management of gout. So look, obesity, diabetes, hypertension. So in this patient, I think those things, I don't know, I may have missed a few slides, but it's part and parcel of the management of this patient, and indeed the management of gout. So control of blood sugar, control of blood pressure, it's no longer managed in isolation. In fact, weight loss, the recent evidence that weight loss actually solves a large part of the problem of hyperuricemia and gout. So in line with that, other agents that can be uricosuric include amlodipine and some of the lipid-lowering agents, particularly the fibrates like gemfibrozil, clofibrate, and then fenofibrate, which is what we use here, fenofibrate. And then another thing about the presentation, one of the radiological features mentioned was sclerotic margins and then rat bite erosions, and then I think they were mentioned separately. Actually, the rat bite erosions are still the same erosions that have sclerotic margins. They basically look at like as if a mouse had beaten out part of the edge of the bone. And these sclerotic margins are how we differentiate them from the marginal erosions of rheumatoid arthritis. And then, of course, where they are located. If they are located on typical joints, like the first metatarsophalangeal joint, that's another way we differentiate them. So the sclerotic margins are actually characteristic of rat bite erosions. They are not really separate phenomena. Then the classification of primary and secondary gout. Now that actually can be confusing, but basically all the inherited or genetic causes of gout are the primary are what are classified as primary gout. All other causes, which can be broadly classified into urate overproduction and urate underexcretion, are the causes of secondary gout. So the ones that are actually considered primary gout are those inherited causes, superactivity of the phosphoribosylate enzyme, the HGPRT deficiency. Those genetic inherited causes are the ones considered as primary gout. But every other thing, drugs, hypothyroidism, hyperparathyroidism, CKD, every other thing is considered lead poisoning, hemolysis syndrome, All these other causes are considered secondary gout. I think these are the comments I have. Thank you.
Thank you, Dr. Sekeme, for
Thank you so
a
much.
wonderful contribution. So let me go back to the chat box. Okay. So Dr. Itoha will say, what are the purine-containing foods? What is the duration of treatment? I think you mentioned it. And Dr. Jamila is saying, at what uric acid level do we start treatment in an asymptomatic patient? So those are the few comments.
Okay, thank you for your questions. Basically, the purine-containing foods are meat, then some fruits like apple, apricot, banana, and then some seeds. I've also like bean seeds, cashews, cheese, all of those are high purine-containing foods. So basically, as like I listed in the non-pharmacological management, you need to reduce purine foods, even foods that have high fructose like sodas, weight loss, and other things that I mentioned in non-pharmacological management. So those are the purine-containing foods. Then from my understanding, hyperuricemia can be treated like reduction in the uric acid levels. But if you're basically if the levels are elevated above the upper limits of normal, you may want to treat the patient, but that does not mean the patient has gout. So if you're just treating the hyperuricemia, not that the patient, maybe to reduce the cardiovascular risks and all of that, but not that the patient has gout. So it's when there's hyperuricemia with symptoms, or maybe a normal uric acid levels, but the patient has the typical symptoms of gout, that's when you're instituting treatment for gout. Once the levels, if you want to treat for hyperuricemia, once the levels are above the upper limit of normal, you want to treat, that's fine. But if you're treating for gout, hyperuricemia has to come with symptoms, or normal uric levels with symptoms, that's when it is gout and you should institute treatment. Then what I saw is the target levels, which I mentioned earlier. The target levels, the treatment, like I said, we target less than 6 milligrams per DL. If the patient has just gout, the patient already has esophageal gout, renal complications, we target less than 5 milligrams per DL. So if we're using the xanthine oxidase, we start at 100, we titrate against the levels of the hyperuricemia. Once we get to normal levels, we maintain the patient for 6 months. Once the patient is stable and normal, we leave the patient. So we withdraw the drug, and then every 6 months, the patient can be coming to do uric acid levels to make sure the levels are still normal. That was what I saw concerning the treatment. I don't know if it answers the question. Hello, sir. Am I audible?
Yeah, audible. Yes, we can hear you.
Okay, so that's
so
any
okay.
other.
Dr. Cassidy is asking, do you use NSAID and colchicine concurrently for the duration of treatment? Do you give NSAIDs for 6 months?
The agents for treatment of gout can be combined depending on what you want to achieve. And then the NSAIDs that are given for 6 months is basically prophylaxis. So those are low dose NSAIDs, not high dose NSAIDs. And then you also take into consideration the side effects of NSAIDs to watch out for them and then address them if it comes up. But usually for the prophylaxis, which we do for at least 6 months, they are low dose NSAIDs. I don't know if there's any other question.
Is there any recommendation for to screen for hyperuricemia routinely? Is it recommended?
Yeah, hyperuricemia, screening for hyper.
Yes. Hello?
No,
Okay.
sir, I don't know. Someone wants to make the contribution. Can I go ahead?
Okay, go ahead. Well, we're waiting. Yeah.
Okay. So screening for hyperuricemia. Basically, most of our patients that have increased cardiovascular risk. Uric acid is one of the risk factors for cardiovascular disease. So if you're screening for that, yes, we usually screen our patients that have increased cardiovascular risk. We check for uric acid. But if it's that all patients that come into clinic should be screened for uric acid to be able to diagnose gout. We have already said uric acid is not diagnostic. Hyperuricemia is not diagnostic of gout. So it's not like screening all the patients will be able to say if this person has hyperuricemia, that means the person has gout. No. So if a patient has increased uric acid levels, you can commence treatment to reduce the uric acid levels. Doesn't necessarily mean gout. So I don't think that regular screening of everybody for hyperuricemia is recommended, except maybe you want to use it as maybe like the patient has increased cardiovascular risk to look for the risk factors for his cardiovascular issues, then that's fine. But for every patient that comes to the clinic, we screen for hyperuricemia. I don't think it's a recommendation because even the hyperuricemia is not diagnostic of gout.
Hello?
Please, contributions. Yes,
Hello?
go ahead.
Yeah, we can hear you.
Hello? Dr.
Yes,
Okay,
we can hear you.
let me just contribute to this. There are certain situations where screening for hyperuricemia is important, and they include situations like somebody who already has metabolic syndrome, okay, because it's actually a part of diagnostic criteria, okay, or as she said, someone that already has high cardiovascular risk. Then we also even these days, hyperuricemia has been associated with heart failure and all that. So, but I don't think they have adopted it as urine testing in patients that have heart failure. Then for us in CKD, studies have shown that hyperuricemia is an independent risk factor for progression of CKD. So for nephrologists, managing hyperuricemia is important. So if uric acid is high in a patient with CKD, we have started managing it, okay. Even though I don't know some nephrologists, but most nephrologists now manage hyperuricemia. But the teaching is that hyperuricemia does not require treatment on its own, and you don't even need to screen for it routinely. Okay, so on its own, hyperuricemia does not really require treatment. Okay, so if someone, unless some of these conditions that I've mentioned are present, then you now want to treat. I think that's what I know about hyperuricemia. Thank you.
Thank you so
Thank
much.
you very much for
Thank
your
you. I
contribution.
think we should move over to the next presenter, Dr.
Okay.
Ede. Thank you so much. It was such a wonderful presentation. I must appreciate the active participation from the house, from our teachers. Thank you so much. Thank you, Dr. Asekeme, for coming in. Thank you, Dr. Aka. Thank you, everyone.
Sorry, Chief. I want Dr. Asekeme to quickly comment on something.
Okay, you can go ahead.
Okay.
Hello, ma. All right.
Yes, can go ahead. Yeah.
We had some examiners are still having issues concerning commencement of the xanthine inhibitors at the acute phase, that we have differences of opinion. And even during part of the update last time, they were saying, they will see a particular one of the examiners saying this is own stand. That doesn't mean that others don't have their own stand. So for the rheumatologists, what are the current trend in terms of commencement of xanthine oxidase inhibitor from the beginning as an acute rather than patient being on it before? Thank you, sir.
Okay, thank you very much. The teaching has always been that the xanthine oxidase inhibitors should not be commenced in an acute attack unless the patient was already on one. So there was a slight variance to this in 2019 at the American College of Rheumatology Convergence, where there was, in this thing called the Great Debate, there was a group proposing that there was no difference, basically, in using xanthine oxidase inhibitors from the start in conjunction with acute phase agents. The acute phase agents we use, of course, we know are NSAIDs, colchicine, steroids, ACTH analogs, and then the IL-1 blockers. So this group was proposing that you could use xanthine oxidase inhibitors along with one or more of the acute phase agents right from the start. That has not, as far as I know, been widely accepted. If it's been practiced as an expert opinion. It has not been adopted, as far as I know, into guidelines. And most rheumatologists, including my boss, continue to practice what has always been known. And that is starting with the acute phase agents, one or more of them, and then usually you expect the acute attack to have been quelled within the first 10 to 14 days. And between the 10 to 14, you may start one of the xanthine oxidase inhibitors. Thank you.
Thank you very much, Dr. Asekeme, for the clarification. Well, Dr. Anthony is directing a question to Chief Remigos that what is the treatment of hyperuricemia in CKD patients? Chief, sir. I don't know, Dr. Remigos, are you in the class?
Yes, I am. What? Please, I didn't hear the question. What's the question?
He was asking what is the treatment of hyperuricemia in CKD patients.
Oh, okay. So we just want to lower the uric acid because some studies have shown that it's an independent risk factor for progression to end-stage kidney disease. So whenever it's abnormal, we want to lower it to normal. That's just it.
Okay, sir. All right, sir. Thank you very much, sir.
Right.
Dr. Temi, you have you're already running behind schedule, but you have 15 minutes to give us your presentation. So go ahead.
All right. Good morning, everyone. Hope I'm audible and you can see my slide.
Yeah, you're audible and we can see.
All right. Good morning, teachers, senior colleagues, and colleagues present. My name is Dr. Temitope Fakmunda, and I'm going to be answering the NPMCN November 2023 question 6. Okay, so it's a scenario of a 32-year-old patient with sickle cell anemia with a steady state PCV of 17%. Patient has been regular on clinic follow-up, but not regular on her medication, hydroxycarbamide. Between her last visit and this visit, she has lost about 8 kg. There are no changes in her biochemical and hematological results. Now she has an abdominal ultrasound scan done, which showed gallstones. So the scan image was what was presented, not the report. So the task is to talk to the patient about the implications of her test. So I just decided to include some ultrasound images showing the liver and the gallbladder with a stone in it. So the stone is casting a shadow marked by the arrow. And this is another one that shows a bigger stone, also causing a posterior acoustic shadowing. So it's a communication station. So I will start by introducing myself to the patient and explaining the purpose of the interaction. Then
Sorry, excuse, Doctor. Did you need to have a simulator?
Okay.
Dr. Atta, this is a communication station. Get a simulator and a timekeeper, please.
Okay, so Dr. Fatima, can you be the simulator since you went for the exam? so that you can guide us appropriately. And then
Sorry, I'm
Dr.
just
Jemmy.
sorry, I can't do that. I'm just taking my child to school now.
Okay. Dr. Christabel, can you help me here?
Just choose anybody from the class. They can...
After we usually
Okay,
appreciate you call
Let me be the simulator.
Yes.
But we usually encourage you call participants, not our facilitators. Let participants get into the art of doing some of these things. It will help. I think we have lots of people in the class. He said, has anybody volunteered?
Alex, it will be. Alex,
Alex. Okay, Alex.
Thank you, sir.
Sorry, I'm moving. I'm rushing to drop my children's school.
You say what?
I'm rushing to drop all my children's school. I'm so sorry. Anybody can...
So I can simulate for her.
Okay, Dr. Success.
Okay.
No, I wanted to simulate, but if you simulate it, no problem. I can be the timekeeper.
Okay. All right, then go ahead. Doctor.
How many minutes, please?
I think 5 minutes or 7 minutes.
Okay, she can start.
She
can start, please.
All right, thank you. My name is Dr. Tinitope Fakonda. I'm one of the senior doctors in the unit, and I'm going to be having a discussion with you regarding a test results you came with to the clinic. Can I go ahead?
Yes, please.
All right. Are you okay with this office, or do you want us to go somewhere else?
No, it's fine. I can stay here.
Okay. Did you come with any other person, maybe your husband or your siblings, any other person you would like to join the discussion?
No, I'm alone today.
All right. All right, you're welcome. Just some background information. So I've been told you are 32 and then that you attend the clinic on account of sickle cell anemia.
Yes, that's what they said.
All right, ma'am. So what kind of work do you do?
I'm a banker.
Okay. All right. Are you married?
Yes.
All right. Thank you. So before we go ahead, I understand you have sickle cell anemia and you attend clinic, and you came today because you came with a result. So do you have any concerns, that you would like me to talk about before we go into test results?
So I've been having this pain, and so based on the condition, they told me to be taking some drugs, and it's not easy taking drugs and keeping up with it. And then I started having this pain, and then I came back again, and they did a scan that I don't know what the scan is showing, but the pain is quite bad, and I just want to know what's happening. I want to just get better and feel better as much as possible.
Oh, all right. Sorry about that. Okay, so how much information would you like me to give you regarding this your test result? Do you want full details or just a little bit?
I want to know everything. No, I want to know what is happening. I want to know what to do. I want to get this thing over with. I want to be fine. So just tell me what needs to be done, as soon as possible, what I need to do, what I need to take, how I need to take it, and then, so I can feel better.
All right, ma. So first of all, the results you came with is the result of the ultrasound scan that you did, and it's showing that you have what we call gallstones.
Sorry?
It shows that you have what we refer to as gallstones, so stones like little rocks.
From where?
So,
How did stones get in there?
okay, ma. So, first of all, the organ where these stones are located, so it's called the gallbladder. It's a small organ just below our liver and usually contains some juices that are important in digesting and absorbing food and nutrients. So, one of the things that make up these juices is a product of breakdown of our blood that's called bilirubin. And then because you have sickle cell anemia, so one of the manifestations is that there's ongoing breakdown of your blood cells, which results in increased production of this bilirubin, which makes the juice in that gallbladder to get thick and then form stones. So these gallstones are actually very common in people that have sickle cell anemia, and usually starts forming from a young age. And most times it may not really cause any symptom. You may not really know anything about it, except they just find it routinely. However, unlike in your case where you had some complaints, which is why you went ahead to do the scan. So, like I said, it's very common in people that have sickle cell disease. Now, some of the common symptoms that it may cause is it could be causing, occasional pain in the upper part of your tummy that you can feel the pain all the way to your back, and sometimes the pain can be triggered when you eat fatty food. And then sometimes if the stones have been there for a while and have been causing some problems with the liver and the pancreas, some other organs in the body that are important in absorbing nutrients. So it could explain the weight loss we're having, because if there are some problems absorbing the fats from the food that you've been eating. So those are some of the symptoms. And sometimes if the stone is trying to pass, it could give you some acute sudden abdominal pain in your tummy that can be so severe that might require you presenting to the emergency room. And then
1 minute 30 seconds remaining.
Okay. And sometimes sometimes this pain may make it difficult for us to differentiate between the pain crisis that you may have and these stones. So that is why it's something that now that you have noticed that's giving some concerns, we need to address it. Now, treating these gallstones involved different specialists. So your hematologist will work with the doctors called hepatologists that deal with disease of the liver, and sometimes we may need to involve surgeons, because ultimately the way to treat these gallstones is to actually remove that organ, the gallbladder, prevent further complications. All right, Ma. So can you just tell me what you've understood by what I've told you so far?
Okay, thank you. You said there are stones in my body, somewhere under my liver. I don't know how it got there, but you said it's because of the condition that I have, and my cells are breaking down. And because the cells are breaking down, that thing you called one name is cleansing the system, and then it's going there, and it's causing the problem. And you also said that, well, all those things you were talking about, I'm feeling them small, sometimes you just have that pain. So I kind of agree with what you're
7 minutes
saying.
already. The time is up.
No, just round up.
Okay, Ma. All right, thank you so much. I just want to also ask, I noticed that you've not been using your drug hydroxycarbamide. Any issues? Are you having challenges with the drug?
Don't like the drug at all. The taste, the size, the everything about the drug, and then I have to take it every day for something that even I don't like the drug. I don't know. I really don't know. I just don't like it. It's too stressful taking drugs. And then I feel like I'm not getting better. So why am I using it,
All right, I understand about your concerns and challenges having to use a particular drug all the time. So I'm going to give you a leaflet about hydroxycarbamide, the benefits, for sickle cell anemia, why it's important you try to use it as prescribed. Okay, so thank you so much for the discussion. So regarding the result, the gallstones, I would refer you to the doctors I talked about, the hepatologists and the surgeons, so that they could also evaluate you and give you some more information. And also, I'll see you in the clinic in 2 weeks for a review of the progress we've made so far. Thank you very much, Ma.
Thank you very much.
Yeah, thank you, Temitope and Blessing, for the presentation. So the class is open for contributions, questions, and comments. Okay, Dr. Tanimu.
Please, can you go back to the question so that I can see the question? Then the contributions can go on.
Dr. Tanimu, you can go ahead.
Thank you very much for this simulation and also for the presenter. As the presenter should try to be using English term, not the medical term, in conversation like this, like saying complications. Complications is more of medical, but if you can substitute it with problems that may arise in your body, it's more, and also evaluation. Sometimes they may not be very conversant with the word, but you can say investigation and also check up to find out the problems. So always try to use English term when you are conversing with a person, with a patient, because some of the medical terms may not be very understandable for them. And also when you are interacting, you should be straightforward to solve your task, not to go beyond or above the task given to you. And also this, when they said this hydroxycarbamide, you know, patient with on hydroxycarbamide have indication. Patient with recurrent blood transfusion, patient with recurrent hospital admission, sickness with recurrent blood transfusion, with recurrent crisis, those are the indications. You have to find out what are the reasons and what are the concern of avoiding the medication. Thank you very much. But you have done very good job. Thank you very much.
Thank you very much.
Yeah, thank you, Tanimu, for your contribution. Any other contribution? You can type your comments in the chat box, or you can raise your hand and contribute. Any other contributions? So Dr. Roberts is saying, is there an alternative drug? So I don't know, alternative. Temitope.
So the hydrocarbamide.
Yes, I think.
Okay, thank you for the question.
And how do you improve? And how do you improve? A follow-up question: how do you improve adherence?
Adherence. Okay. Thank you for the question. So there are actually new studies and evidence. So hydroxyurea has over 25 years of use in sickle cell with good efficacy and tolerability. So right now it's actually indicated in all patients with sickle cell anemia across all age groups. So the traditional indications of the recurrent crisis, are no longer very much up there. So it is recommended in all patients with sickle cell anemia because it has so many, it's like a disease-modifying therapy, and it has so many benefits both for the thrombotic and the vasculopathy and the long-term complications involving the lungs, the heart, and neurocognitive. So it has so many benefits. So there are alternatives actually. So there are some other disease-modifying therapies that can be used in sickle cell disease. So there's L-glutamine rather. Then there's crizanlizumab and voxelotor. So these three other agents are also disease-modifying therapies that can be used in place of hydroxyurea if the individual cannot tolerate the hydroxyurea, or the major limiting issue with hydroxyurea is fertility. So if, for instance, if she's a female and she gets pregnant, then the other agents may be considered. And if it's a male that is planning to conceive, then it has to stop the hydroxyurea at least 3 months before attempting. And then these other agents can actually also be added to hydroxyurea for improved benefit. So, but in terms of improving adherence, so things like discussing the drug, preferably with a patient information leaflet that highlights all the benefits, so the patient can actually go through, and then letting the patients know that it has very minimal side effects. Some of the fears patients have, okay, so they have heard that it's a drug used in managing cancer, or that there's a risk that they can have cancer. So it's important to let them know that there's no evidence supporting that. Then in terms of fertility, like I said, so for the patient needs to be on contraception, and then if she's trying to conceive, then she would stop it, and same applies to the males. And then if the problem has to do with cost, then counsel the patient to try and get health insurance if that's feasible. I think those are what I can think about to encourage the patient to comply.
Okay, thank you. Thank you for it. So, Dr. Fatima, you want to say something?
Yeah. Thank you very much, Doctor, for that brilliant interaction. My comment is regarding the patient education. I think it's very important to have taken the patient from the basis of sickle cell disease. How did she get this disease? What exactly is happening if someone has sickle cell disease? So if you take her from the basics, that it's a disease that is inherited, and the red cells should be like roundish in shape. In her own case, they may take sickle shape when there are triggers like dehydration, or when there is low oxygen in her body, something like that. So you need to take the patient from the basics, let her understand what exactly the problem is, what are the triggers, and then the importance of taking her. Why is she not adherent? Because from the question they said the patient has not been compliant with her medication. So find out why she's not compliant, so that you try to address the issue of the adherence. And also you flow down to the complications of sickle cell disease, among which is this gallstone that she had. As you rightly mentioned, you discuss the management of the gallstone. That's excellent. And you have to avoid medical jargons as much as possible. You use a lot of them. I don't know if it's because you were taken unawares, but you need to improve on your communication skills. Avoid medical jargons as much as possible. Thank you.
Thank you very much, ma'am.
Thank you for your contribution. Dr. Itohan is asking what could be the cause of her weight loss of about 8 kg.
Okay, ma. Thank you for the question. So, in my discussion with her, I tried to highlight that it could be related to the gallstones, because in sickle cell patients, the gallstones develop very early from when they are young, and she's 32. So they could have this chronic pancreatitis related to the gallstones, or she could be having fat malabsorption that could explain the weight loss relating to the gallstones. For other causes of the weight loss, further history will have to be taken if we are looking outside of the task that we were given, which is the ultrasound scan results. I believe that, which is one of the reasons why she's being referred to the pathologist for further assessment, because the gallstones, she may also have stones in the biliary system, not just in the gallbladder.
Hello? Can you hear me?
Yes, sir.
Okay. So thank you. Any other contribution? We have spent our time. So to our teachers, any contribution from?
Thank you. Dr. Fatima is part of our teachers, so yeah, summarized already. Dr. Fatima, thank you. I think most of the comments I want to make have already been brought up already. I want to just emphasize on the medical jargon she used quite a number. So, but I'm sure she have gotten the message already. So Dr. Temi Tokwe, thank you so much. Dr. Ede, thank you so much. It was a wonderful presentation today. Both did wonderfully well. Thank you. Thank you. Then our teachers, thank you for coming to class. I appreciate your wisdom.
Hello.
Very good, sir.
Yeah, Dr. Christopher, I want to make some comments.
Okay, sir.
All right, so thank you. And I really enjoyed today's class. Thank you guys. It was just beautiful. Yeah, so one of the reasons I told her to go back to the question is sometimes you get carried away in this kind of stations. Always try to answer the question. All right? Okay, so like when Dr. Fati was talking about going to the basics and all that, the first thought that came to my mind is one has to be careful about that. It's good to go to the basics, but you need to be fast about it. Don't forget that you're supposed to answer the question, okay? One of the reasons for going to the basics is that the patient will completely.
Yeah, kuna lahiya. Akwai wani bayani da Ahmed? Ka ba komi Ahmed.
I hope you can hear me.
You can be heard.
I hear you.
Okay, so yes, so that the patient will completely understand, but don't get carried away. I always tell people about my my part 1 exam when I got to a station on CKD. The question was somebody came with a result. I'm supposed to just tell them the treatment or the management options for CKD. You know me, even from this thing, I was already inclined towards nephrology. So I just got excited on the station. I first started talking about CKD, talking stories. By the time I now said, now for the management, I just heard bang, time was up. At the end of the day, I'm sure I failed that station despite all my stuff. And while I was talking, my examiners were just nodding as if I was saying correct things. But they were not ticking, they were not marking anything. Okay, so now the question was straightforward, the implications of this investigation results. Okay, so, and I like the way she went ahead talking about it, what it meant, the management options involving the surgeons and all that. But I felt as if she didn't stress that enough. The truth is that the management option here is surgery. Okay, so she just put it as if it's an aside. No, that's the main thing, is surgery. And you must make her understand that they might have to remove the gallbladder, okay? And then just as everybody has been saying, a lot of jargons. I also felt as if things like when you're explaining the bilirubin, for example, if you had related it to, say, the jaundice that she knows she has, this is this same thing that causes this yellowish discoloration of your eyes. It's part of the thing that forms this thing in the organ that we're talking about. So the patient might relate more to it. Then the final contribution I have is on adherence. sometimes there may be need to involve adherence counselors. And, you know, especially national, they like when you talk multidisciplinary. So you can add that to it. Somebody that would talk to them more about adherence or about the use of their medication. You know, so, many setups incorporate it into their care, especially for a medication as important as an hydroxyurea. Okay, so I think these are the comments I have. Thank you.
Thank you very much, sir.
Thank you. Thank you, Chief Remington. So thank you, Dr. Emitokwe. Thank you so much. Thank all the participants. Thank you for coming to class.